I'm David Berger. I'm the CEO of University Hospital at Downstate. I've been the CEO there for almost 3 years. In September will be 3 years. And a disclaimer is I am really excited about digital health, regardless of what my title is and what I'm going to talk about. I think digital health long-term will ameliorate a lot of the disparities we see in the delivery of healthcare. However, it's not going to be a straight line to get there. There's going to be a lot of bumps in the road until we really achieve healthcare equity or healthcare justice. And I'm going to point out some of the issues, it's not comprehensive, some of the issues that pertain both to disparities in healthcare providers like the hospital I run, as well as disparities that impact individual patients. So this is University Hospital at Downstate. We changed our name. We are a small academic medical center. We have 350 beds, but usually our average daily census is about 160 to 170. We treat a population, I'll talk a little bit more about that is funded 85% by government payers, 50% Medicaid, 35% Medicare. So what does that mean? That means that our hospital does not generate a margin. So we struggle in terms of replacing capital and building out capital and systems. We don't have an innovation center. We don't have a lot of capacity to trial digital health innovations and be on the cutting edge of that. So, and then also, and I'll talk a little bit about this, we also, our basic digital infrastructure also is impacted by who our payer mix is. And for those of you who are not in healthcare delivery, most institutions and the NYPs, NYUs of the world have significantly lower Medicaid populations, and they supplement their deficits from Medicaid and Medicare through having really good commercial contracts. We can't do that. So where do we live? We live in the middle of Brooklyn. I don't have a pointer, but you see 27, there's a little thing next to Prospect Park. It's a little suitcase. That's us. We are in central Brooklyn. The dividing line, and I divide the Brooklyn into 4 quadrants based on Flatbush Avenue, which runs north-south, and Atlantic Avenue runs east-west. So the lower quadrant, where it says Dyker Beach Park, that's very working class, good insurer, NYU is there. You go to the top where it says IKEA, that's downtown Brooklyn by the Barclays Center. That's near where New York Presby has put up an office. If you go to the east of us, there is basically no other providers between us and Jamaica Hospital, which is a city hospital, all the way in Queens. And the reason is because of the patient population. So we know that health care disparities are a direct result of what are called social determinants of health. And what does that mean? That means education and access to quality education. It means access to healthcare and quality healthcare. And if you look at our neighborhood, it is a primary care desert. The COVID wiped out most of the primary care providers in central Brooklyn, and they have not significantly been replaced. So our patients have problems accessing healthcare. Neighborhood and build specifically, we have people who live in 5th floor walk-ups. We have issues with childhood asthma because of the environment. Economic stability, most of our patients live below the poverty line. And then there's social and community context in terms of support. We have a huge population of single women whose partner is incarcerated, 25% of the households. So huge social determinant of health issues that impact the health care and the health of the people in our community. So, like I said, I'm going to talk about the issues pertaining to the hospital as well as the issues pertaining to individuals. I put up this, and this is Epic, and the reason I put this up is because my providers have Epic envy. And what does that mean? I have another system, and when I got there, we had version 17. We were five versions behind the current version. And why is that important? Because first of all, it makes it very difficult for our users to function, meaning our providers, which contributes to burnout. The number one cause of burnout for physicians and nurses is the issue of having burdensome EHR. Second thing, if you don't have a good EHR, you can't document correctly, which impacts your quality data as well as your reimbursement. So because we're relatively small, independent, and also we don't generate a margin, we can't afford a system like Epic. And that's why my providers have Epic envy. So another major social determinant of health, and actually a super social determinant of health, is what is called the digital divide. And the digital divide, there's two main factors contributing to the digital divide, and that's access. Specifically, only 57% of people who earn less than $30,000 have home broadband. So think of that during the COVID pandemic and all the people trying to get care through telehealth. Not having broadband access is a major factor in being able to access digital healthcare. The other major issue and contributing to the digital divide is the issue of digital literacy, meaning people understanding how to turn on the computer and basically working it, how to navigate through the internet, how to search, assess the reliability of what they search, generate their own content and contribute to their digital health record, and finally, protecting privacy. This is my 86-year-old mom, and she is digitally illiterate. And this is a problem seen amongst seniors universally. 20% of people have some form of digital literacy. I've tried to teach my mom how to work an iPad and simple things, searching it, turning it on, looking at pictures, at least half a dozen times. Just last week, I got 60 pictures from her phone or whatever downloaded directly to one of the albums in my phone, and they had nothing to do with the album that she was actually downloading it to. And when I asked her what happened, she goes, I don't know how it got there. And that's opposed to my 2.5-year-old granddaughter, who knows how to pick up her parents' phone, search for the videos she wants to see, identify the pictures, go on FaceTime, turn off FaceTime when she's done talking. This is a major issue in terms of disparities in digital health. It's the issue of how do we get digital health to our aging population, and that population is going to continue to grow over the next several years. We have really moved significantly forward in remote patient monitoring. And remote patient monitoring, however flavor you want to use it, relies on sensors. There's a major issue for people of color, dark people, and the sensors being able to pick up what they need to pick up. So it's been shown that O2 sat monitors are inhibited by people with darker skin. It's also been shown, and there are now digital apps that are capable of diagnosing skin cancer. However, these are highly inaccurate in people of color. So as we deploy remote patient monitoring, we need to consider the issue of skin tone. I'm going to switch gears a little bit now and talk about problems with algorithms, large language models that contribute to artificial intelligence. These are all ranking systems of US hospitals. They all use different algorithms to come to their conclusions of rank for the various hospitals. There is no transparency within their algorithms. They keep them all secret. So it's very difficult to know what's in the algorithms. But the rankings determine who will come to your hospital, your ability to market your institution, how you look to insurers as well, meaning how you can negotiate contracts. The one thing that's in all of these algorithms about ranking hospitals is HCAHPS. It's the Hospital Consumer Assessment of Healthcare and Provider Systems, or the Patient Satisfaction Surveys, simply. And for 3 years, I've been banging my head against the wall, trying to improve our response to the HCAHPS and trying to increase our HCAHPS. There's multi-million-dollar businesses around this. Well, it turns out that 50% of my patients speak Haitian Creole. CMS only allows the HCAHPS to be translated into English, Spanish, Chinese, Russian, Vietnamese, Portuguese, and German. So none of the languages around the African diaspora. So we're negatively impacted because this is in the algorithms and this is CMS rule. Now, medical algorithms really are important to understand what's in the algorithm, and there's no transparency in most of the algorithms. And there is multiple studies that show that medical algorithms are failing communities of color. They are introducing bias. And it may be unintentional bias, but they're introducing bias, and because most of these algorithms, the majority of patients, are not people of color. So I think many of you know the story of chronic traumatic encephalopathy in football players. Well, the NFL settled with the NFL Players Association for $1 billion, and then they had to give out the money. Well, it turns out in the algorithm for how you're going to give out the money was the cognition of the person at baseline. And the assumptions put into the algorithm was that people of color have lower baseline cognition. Think about that. Think about the bias introduced in that algorithm and how that affected players who were affected by CTE from getting paid. Transplant and listing African Americans and people of color on transplant lists is directly impacted by the algorithms that predict who are the sickest patients. In kidney disease, there's one blood test, glomerular filtration, that is important in determining how well your kidneys are functioning. For Black patients, they are ranked as healthier in the algorithm for the same exact GFR, same exact, which means they need to be a lot worse off to get on a transplant list than a white patient. And if you look at the data in terms of transplantation for people of color in this country, you'll see that there are significantly less transplants done proportionally to the population for patients of color. This is a really interesting study, and what they did, they wanted to tailor increased interventions to people who were costing the health system more money. So they took data from hospitals and compared how much was being spent on white patients versus Black patients, concluded that these white patients needed more services, and they provided more services to the white people. The problem is the issue of access. And what treatments, African American is much less likely to give a treatment for certain diseases than a white person. So, and then they also proved that the blacks and African Americans in this study were actually sicker than the white people. And the Caucasians were getting much more services than the African Americans because of the problems with the algorithm. The problem is not just simple to remedy. You'd say, oh, just take race out of the algorithm and it would be perfect. Well, this study just hit a couple of weeks ago. And what they showed is when they took race out of 4 different algorithms looking at recurrence after colon cancer surgery, the blacks were biased when race was taken out of the algorithm. So it's not we could just have a blanket solution, oh, let's just take race out of all our algorithms. We need to be careful when we modify the algorithms to make sure that we aren't unfairly biasing different populations depending on what's included. It's not easy, but it is an issue. And the main issue is there's not a lot of transparency to these algorithms. And finally, the last disparity I want to point out is the issue of underrepresentation of minorities in clinical trials. And these are all clinical trials, but if you sit in this room and you listen to some of the startups and the digital companies, this also applies to studies of digital health. Studies of digital health tend to lack representation across racial and ethnic groups. So whereas 13.4% of the population in the United States are Black or African Americans, there's only 5% representation in clinical trials. For Hispanics in the US, it's even worse. 18.1% of the population is currently Hispanic. Only 1% of population is in is represented in clinical trials. So what can we do to address some of these issues? So the issue of participation in clinical trials and digital health studies has been looked at by the NIH. And what they are recommending is community-based participatory research, meaning the researchers that are in the academic medical centers or other places interact directly with the community to understand the community needs, the community barriers to participation. This was successful during COVID, if you remember, in terms of trying to get people vaccinated. The places that did it the best were the ones who really engaged the community in why to vaccinate and use community resources. One of the best programs right now in terms of a CBPR is the FAITH program, which is called Fostering African American Improvement in Total Health. And this is in Minnesota, and it's being done in Minneapolis specifically with the faith-based institutions within that city. And they've seen significant improvement in the number of people, minorities, participating in clinical trials. I'm going to finish here, and I pointed out some of the disparities, a couple of major things to address them. One is the issue of broadband access, and that is something that the feds have looked at and really need to help support. The other is the issue of digital literacy, and when we look at digital health solutions, we need to make sure that the people that we are intending to use them are literate and supported to make sure they get the optimum benefit from the digital solutions. There's controversy in the difference between equality and equity. I think this picture lays it out pretty clearly. Equality is giving everyone the same benefit, but not everyone needs the same benefit. There are people who need different things to make sure they get the same outcome. But what we're really striving to, and I think digital health will eventually help us get there, is justice. But we need to realize what we're doing has the potential to exacerbate bias and disparities, and being very thoughtful of how we proceed. Thank you.